Alterations of hematologic function in children. Iron deficiency anemia, or IDA, is the most common nutritional disorder of infancy and childhood. It can result from insufficient iron intake, problems with iron absorption, chronic blood loss, or increased iron requirements during growth. Children with IDA often present with irritability, reduced interest in play, and noticeable fatigue or weakness. Decreased activity tolerance may also be observed. Hemolytic disease of the fetus and newborn, also known as erythroblastosis fetalis, is an alloimmune condition. It occurs when maternal antibodies attack fetal red blood cells due to blood group incompatibility. This is most often caused by ABO incompatibility and less commonly by Rh incompatibility. Clinical signs include anemia, high bilirubin levels, yellowing of the skin known as icterus neonatorum, and in severe cases, kernicterus, which is neurologic damage from bilirubin toxicity. This image visually reinforces the concept of hemolytic disease in the newborn. Maternal antibodies cross the placenta and bind to fetal red cells, marking them for destruction. Management typically involves close monitoring, phototherapy, and in severe cases, exchange transfusions. Sickle cell disease is an inherited blood disorder characterized by the presence of hemoglobin S. This abnormal hemoglobin is formed when valine replaces glutamic acid on the beta-globin chain. Under conditions of low oxygen or dehydration, red cells containing HbS become rigid and assume a sickle shape. These distorted cells can obstruct blood vessels and lead to serious complications. Sickle cell trait occurs when a child inherits one gene for HbS and one for normal HbA. Other variations include sickle cell thalassemia and sickle cell HBC disease. Complications may include vaso-occlusive crises, in which sickled cells block blood flow, aplastic crisis, triggered by viral infections, sequestration crisis, where blood pools in the spleen, and hyperhemolytic crisis, characterized by rapid red cell destruction. This diagram illustrates how sickle-shaped cells obstruct microcirculation, leading to ischemia, pain, and organ damage. Management includes hydration, oxygen therapy, pain control, and in some cases, hydroxyurea or blood transfusions. Thalassemias are a group of autosomal recessive disorders that affect the synthesis of globin chains in hemoglobin. Depending on whether the alpha or beta chains are affected, the disease is classified accordingly. Individuals with the major form inherit defective genes from both parents, while those with the minor form inherit one normal and one abnormal gene. Beta thalassemia involves impaired production of beta chains. In the minor form, symptoms are mild. In beta thalassemia major, or Cooley anemia, the condition is life-threatening. Affected children may require regular blood transfusions and iron chelation therapy to prevent iron overload. Alpha thalassemia involves impaired synthesis of alpha chains. It occurs in four forms: alpha trait, alpha thalassemia minor, hemoglobin H disease, and alpha thalassemia major. The most severe form, alpha thalassemia major, is usually fatal before or shortly after birth due to severe anemia and heart failure. Hemophilias are serious inherited bleeding disorders caused by mutations in clotting factor genes. Symptoms usually begin between ages 3 and 4 and include prolonged bleeding from minor injuries, easy bruising, and joint bleeding. The three main types include Hemophilia A, caused by factor VIII deficiency, Hemophilia B, resulting from factor IX deficiency, and Hemophilia C, which is due to a deficiency in factor Xi. Management often requires lifelong replacement therapy with the missing clotting factor. Primary immune thrombocytopenia, or ITP, is the most common acquired bleeding disorder in children. It is typically triggered by a viral illness and results from autoantibody-mediated destruction of platelets. Children often present with petechia, easy bruising, or mucosal bleeding. Despite its acute onset, the prognosis is excellent. About 80 to 90% of affected children recover spontaneously within 6 months without long-term complications. Leukemia is the most common childhood cancer, arising from malignant transformation of cells in the bone marrow. The two major types are acute lymphoblastic leukemia, or ALL, and acute myelogenous leukemia, or AML. While the exact cause is unknown, it is believed to involve inherited mutations and epigenetic changes. These mutations impair normal blood cell development and allow leukemic cells to accumulate in the bone marrow and bloodstream. The onset of childhood leukemia may be abrupt or gradual. Common signs and symptoms result from bone marrow failure and include pallor, fatigue, bruising, bleeding, fever, and infections. The presence of blast cells, immature, non-functional white cells, in the blood or marrow is the hallmark of acute leukemia. With modern treatment, the 5-year survival rate for childhood all exceeds 85%. This slide shows a microscopic image of blast cells, which are large, immature white blood cells. These cells rapidly divide and crowd out normal cells in the marrow, leading to anemia, thrombocytopenia, and neutropenia. Management includes chemotherapy, supportive care, and in some cases, stem cell transplantation. Non-Hodgkin lymphoma, or NHL, includes a diverse group of immune cell cancers affecting children. Common types include B-cell lymphomas, such as Burkitt and Burkitt-like lymphoma, diffuse large B-cell lymphoma, as well as T-cell types like lymphoblastic lymphoma and anaplastic large cell lymphoma. The clinical manifestations vary based on the site involved, but can include rapidly enlarging lymph nodes or extranodal masses. Treatment typically involves intensive multi-agent chemotherapy. Hodgkin lymphoma in children typically originates in a single chain of lymph nodes and is characterized by the presence of Reed-Sternberg cells. The Epstein-Barr virus is frequently associated with the development of this cancer. The most common presentation is painless lymphadenopathy, often accompanied by systemic symptoms such as fever, fatigue, weight loss, and loss of appetite. Treatment includes chemotherapy, radiation, or both, and is highly effective in most cases. This image shows Hodgkin lymphoma pathology. With timely diagnosis and proper staging, the prognosis for pediatric Hodgkin lymphoma is excellent. Treatment success rates are high, and long-term survival is common. However, attention to minimizing late effects of therapy remains a priority in survivorship care.